Heavy menstrual bleeding in adolescents, TOG 2024. Contents include background, menstrual cycle in adolescents, etiology of heavy menstrual bleeding in adolescents, assessment, including history, examination, and investigation, management, and the special considerations, which include consent, learning disability, and the management of acute heavy bleeding. 16% of the population worldwide are adolescents. NICE define heavy menstrual bleeding as excessive menstrual loss, which impact the woman's quality of life, or where sanitary products are changed every 1 to 2 hours, or where menses last longer than 7 days. The prevalence of heavy menstrual bleeding varies widely in publications, ranging from about 5% to 37%. Heavy menstrual bleeding is the most common gynecologic reason for referral of adolescents to a secondary care. Regarding adolescent menstrual cycle, the mean age of menarche in the UK is 12 to 13 years old. However, this age of menarche decreased during the last century. The reasons for this reduction proposed to be improved nutritional status and a reduction in chronic disease. Other factors associated with earlier menarche includes African American ethnicity, higher childhood body mass index, estrogen receptor alpha, and the leptin gene polymorphism. The typical adolescent period lasts between 2 to 7 days, and it occurs every 21 to 45 days. Regarding ovulation, in the first year following menarche, about 50% of menstrual cycles are anovulatory. By 2 to 3 years post-menarche, about 70% of cycles become ovulatory. For this reason, the most common cause for heavy menstrual bleeding in adolescents is anovulatory cycles. Regarding etiology, as we said, the most common etiology is anovulatory cycles. However, there are other pathological causes. This includes bleeding disorders, and the bleeding disorder should be considered in adolescents with any of the following: heavy menstrual bleeding from the onset of menarche, history of recurrent epistaxis, excessive bruising, prolonged or unexpected bleeding within injuries or surgical procedures, family history of bleeding disorders, evidence of anemia, and the failure to respond to conventional hormonal therapy. The most common bleeding disorder in the UK is von Willebrand disease. Menorrhagia associated with von Willebrand disease may worsen following menarche. However, the level of von Willebrand factor may increase with acute stress, inflammation, illness, or high-dose estrogen. For this reason, interpretation of the results requires a consultation with a hematologist. ITB is another cause of bleeding disorder, and it is the most common platelet disorder in adolescents, and account for 7% of girls presenting with heavy menstrual bleeding. ITB is a diagnosis of exclusion after excluding other causes of thrombocytopenia by full blood count and peripheral blood film. Inherited deficiency of factor VIII and factor IX is another bleeding disorder. It should be considered in adolescents with heavy menstrual bleeding and a family history of hemophilia. Although hemophilia is an X-linked recessive disorder, it affects males. However, girls who are carriers may display bleeding tendency. Rarer deficiencies include deficiency of factor II, 5, 7, 10, and 13. These are suspected with a positive family history or in patients of Ashkenazi Jewish descent. Endocrinopathies is another etiology. This includes thyroid disease. Hypothyroidism is an important potential cause of heavy menstrual bleeding. It may be autoimmune, which affect 1 in 3,500 children in the UK, but also it may occur due to other causes, such as thyroidectomy, hypopituitarism, iodine deficiency, or radiation. Clinically, it is suspected in women with heavy or irregular menstrual bleeding with associated findings such as goiter, fatigue, myalgia, cold sensitivity, constipation, dry or thinning of hair and skin, low mood, and reduced concentration. In addition, there may be family history of thyroid disease or autoimmune disease. And the condition is diagnosed based on elevated TSH and low thyroxine level. Another endocrinologic problem is polycystic ovary syndrome. It affects 8 to 11% of adolescents, and the diagnostic features includes oligomenorrhea or amenorrhea, and clinical features of excess androgen, which includes hirsutism and acne. However, the diagnosis of polycystic ovary syndrome in adolescents is challenging because the manifestations of PCOS, I mean irregular menstrual cycles, hyperandrogenism, and the multifollicular ovaries, are common finding in healthy adolescent population. For this reason, a new revised international guideline recommended that in adolescents with gynecological age less than 8 years, I mean less than 8 years after menarche, there are no definitive criteria to define polycystic ovary morphology on ultrasound. For this reason, it is not recommended in adolescents. Connective tissue disorders like Ehlers-Danlos syndrome and the childhood onset systemic lupus erythematosus are another etiologies of heavy menstrual bleeding in adolescents. Endometriosis is not a common cause of heavy menstrual bleeding. However, it should be considered in adolescents who present with heavy menstrual bleeding and the cyclical or chronic pelvic pain. It may be overlooked. However, chronic systemic disease may be a cause of heavy menstrual bleeding in adolescents. This includes increased insulin levels due to either supraphysiological insulin treatment in type 1 diabetes or hyperinsulinemia secondary to ovarian insulin resistance in type 2 diabetes. This increased insulin level will result in hyperandrogenemia and consequently anovulation, leading to heavy menstrual bleeding. And in such a case, optimizing glycemic control is associated with a reduction in menstrual dysfunction. Anti-epileptic medications can result in heavy menstrual bleeding. For example, sodium valproate and lamotrigine can potentiate androgen biosynthesis in the ovarian theca cells. This will increase androgen level, leading to anovulation and consequently heavy menstrual bleeding. In addition, enzyme inducers like carbamazepine, phenytoin, and phenobarbital. These drugs reduce the efficacy of combined hormonal contraception if used, increasing the likelihood of breakthrough bleeding and contraceptive failure. In such condition, levonorgestrel IUS, intrauterine device, or dipomedroxyprogesterone acetate injections are the recommended methods for contraception. In addition, vascular liver disease are associated with hyperandrogenism, and 21% of cases experienced heavy menstrual bleeding. Assessment of patient with heavy menstrual bleeding require history, examination, and investigation. During a history, create a comfortable clinical environment and encourage girls to express their opinions and concern. The clinical history is ideally taken both with and without a parent. Encourage girls to keep diary of their menstrual cycles to help evaluation and assess for any potential issues that would raise safeguarding concern. During history, obtain menstrual history, which include age of menarche, cycle length, regularity, number of pads or tampons used, and the impact of bleeding symptoms. Ask about associated symptoms such as dysmenorrhea, cyclical or non-cyclical pelvic pain, dyspareunia, dyschezia, bowel symptoms, weight gain or loss, hirsutism, epistaxis, bruising. Obtain sexual history, including risk of pregnancy, STI, contraception, Ask about past medical history, including chronic illness, bleeding history, obtain drug history. Ask about regular and over the counter medications, family history of bleeding disorder, PCOS, endometriosis, autoimmune conditions, hormone sensitive cancers, and obtain social history. Regarding examination, it is rarely required. If an examination will not be needed, reassure the girl at the start of consultation, as this may reduce the appointment based anxiety. And if examination is required, a chaperone must be present for any clinical examination. Regarding investigations, initial investigations as the following. NICE recommend full blood count for all women presenting with heavy menstrual bleeding. The British Society for Pediatric and Adolescent Gynecology recommend, in addition to full blood count, to measure serum ferritin and the coagulation screen, which include fibrinogen, PT, and the PTT. Further investigations are indicated in girls who fail to respond to medical therapy, or when an underlying pathological cause or complication is suspected. This includes the following. If bleeding disorder is suspected, testing for von Willebrand disease and testing for factor VIII levels, hormonal profile, an elevated TSH and low thyroxine are consistent with hypothyroidism, elevated prolactin warrant further investigations, and if PCOS is suspected, measure serum testosterone, SHBG, and calculate the free androgen index. Testing for STI and pregnancy test in sexually active adolescents who present with abnormal vaginal bleeding with abdominal or pelvic pain, abnormal discharge, or cervical excitation. In such condition, swabs are taken to assess for bacterial vaginosis, candida, chlamydia trachomatis, mycoplasma genitalium, Neisseria gonorrhea, and trichomonas vaginalis. Ultrasound is important to identify pelvic mass and assess congenital uterine anomalies. Regarding management, most adolescents are managed in an outpatient care. However, admission is required if the girl is bleeding heavily, hemodynamically unstable, or there is significant anemia, hemoglobin less than 8 gram per TL. The patient is mainly managed by a gynecologist with a specialist interest in pediatric and adolescent gynecology. However, a multidisciplinary team consultation is required in more complex cases. Encourage girls to make autonomous decisions about their treatment. Verbal information should be supplemented with adolescent-specific leaflets or online resources. Treatment options include non-hormonal and hormonal preparations. Non-hormonal preparations such as tranexamic acid and mefenamic acid. The dose of tranexamic acid in adolescents is 1 gram 3 times per day. It is contraindicated in fibrinolytic conditions, history of convulsions, thromboembolic disease, and it is avoided in severe renal impairment. The dose of mefenamic acid is 500 mg up to 4 times per day. It is contraindicated in active GIT bleeding or ulceration, used with caution in cardiac disease, and it is avoided in renal impairment, avoided inflammatory bowel disease, and it is associated with seizure risk with overdose. Hormonal methods include combined hormonal contraception or progestogen-only methods. Combined hormonal contraceptive can be taken cyclically or continuously, and it includes oral tablets, transdermal patch, or vaginal ring. A monophasic combined oral contraceptive pill containing 30 microgram esenyl and levonorgestrel is considered first line. If the patient develops side effects related to estrogen excess, such as nausea, bloating, breast tenderness, vaginal discharge, Then consider reducing the dose of acenyl estradiol to 20 microgram preparations, or move to a transdermal contraceptive patch. However, this lower dose of estradiol is associated with higher rates of breakthrough bleeding. If there is progestogen related side effects like acne, headache, depression, breast symptoms, consider switching to a non androgenic progestogen. In women with nausea or significant mood changes associated with combined oral contraceptive pills, consider the use of vaginal ring. In women with bleeding disorder, combined hormonal contraceptives are commonly used as first line therapy in adolescents with heavy menstrual bleeding secondary to bleeding disorders. In women with systemic lupus erythematosus, combined hormonal contraceptives are considered acceptable for patients in the absence of antiphospholipid antibodies. However, if antiphospholipid antibodies are present, then the use of progestogen-only preparations are recommended. Progestogen-only preparation can be used if estrogen is contraindicated, such as norethindrone acetate, medroxyprogesterone acetate, the use of implant, levonorgestrel IUS, or debut injection. Northestrone is contraindicated with acute porphyria or history of venous thromboembolism. And take care, its long-term use is associated with hepatic adenoma, and it is metabolized into acenyl estradiol. Medroxyprogesterone acetate is contraindicated in acute porphyria or arterial disease. Desogestrel can reduce glucose tolerance, so take care in diabetic women. Implant, such as nexplanon, is not licensed under 18 years. Levonorgestrel IUS is significantly more effective in reducing heavy menstrual bleeding than oral progestogens or combined oral contraceptive pills. Some girls will require general anesthesia for fitting the intrauterine device. Regarding DIMPA, the long-term use, more than 5 years, is associated with osteopenia. So it is only considered where other methods are unsuitable. Osteopenia is thought to be reversed with cessation of use. Regarding consent in adolescents, young people over the age of 16 years can provide consent using the Adult Consent Form 1, provided they are deemed to have the capacity. An individual is deemed to have the capacity to consent if they are able to understand the proposed treatment and risk and benefits, weigh up and retain the information given, and communicate their decision freely. For those aged 14 to 16 years, Consent Form 2 should be used where parents provide consent. However, the child is encouraged to sign to show their understanding of the treatment. A medical review 6 months after starting hormonal therapy is recommended. It should focus on the current symptoms and the change over the last 6 months, compliance to therapy, acceptability to treatment, and the impact of their symptoms on their quality of life. In adolescents with heavy menstrual bleeding and learning disabilities, regarding treatment, continuous extended use of combined hormonal contraceptive is a popular choice because this reduces menstrual severity, pain, and allows scheduling for withdrawal bleeding. If there is a difficulty in taking tablets, transdermal combined hormonal contraception is an alternative. Dipomedroxyprogesterone acetate has a high rate of amenorrhea, and it is a suitable option for girls with learning disabilities. However, the risk of osteoporosis should be considered. Levonorgestrel IUS is an appropriate alternative, but usually it needs to be placed under general anesthesia. Regarding information in such condition, it should be delivered by a multimodality using verbal, visual, and written information, appropriate for their intellectual abilities. Hospital learning disability teams may attend appointments to support medical teams, and independent patient advocates should be considered in best interest discussions. Management of acute heavy menstrual bleeding depends on the hemodynamic status of the patient. If the patient is hemodynamically stable, assess the patient clinically through history and examination, and obtain investigation to including urinary pregnancy test, full blood count and clotting screen, pelvic ultrasound, and perform additional investigations as indicated. And start your treatment with tranexamic acid 500 or 1000 mg oral 3 times for up to 4 days if there is no contraindication. Iron therapy, if the patient is anemic, it may be iron infusion or oral iron if there is mild anemia. And continue treatment with medroxyprogesterone acetate 10 mg twice or 3 times daily for 21 days. On the other side, if the patient is hemodynamically unstable, insert 2 wide bore cannula. Obtain blood for investigations including full blood count, renal function test, clotting screen, and venous blood gas. Perform urinary pregnancy test and start crystalloid fluid resuscitation. If there is no active bleeding, the patient becomes hemodynamically stable and the hemoglobin is more than 8 gram per dl, then manage the patient as pathway 2, I mean the hemodynamically stable patient. However, if any of these are present, I mean the patient is bleeding actively, hemoglobin less than 8 gram, or she is hemodynamically stable despite crystalloid resuscitation, then start blood transfusion, platelet transfusion if platelet less than 50,000, transfuse clotting factor if there is severe deficiency. Administer tranexamic acid 1 gram intravenous, followed by hormonal therapy, which is medroxyprogesterone acetate 10 to 20 mg oral up to 8 hours, I mean 3 times daily. Consider assessment with ultrasound or examination under anesthesia, and consider the use of balloon tamponade using Foley catheter if underlying bleeding disorder or the patient is hemodynamically unstable, not responding to hormonal therapy.